It's truly an honor and a pleasure to introduce our next speaker, Dr. Kanti Rai, a friend and colleague from Long Island. Dr. Rai's credits are truly too numerous to mention. We'll just highlight a few. He was president of the American Society of Hematology and probably received ASCO's highest award, the David Karnofsky Memorial Award in 2012. He obviously is a pioneer in the study and treatment of chronic lymphocytic leukemia, and I want to thank him personally again for taking the time to come to Tampa to participate in this meeting. So thanks. Introduce Dr. Rai.
Thank you, Stuart. Stuart and I go a long way back when geriatric oncology had not been born yet. And as Stuart said in his initial first few slides, that at CALGB, I can't bring myself to call the mouthful word of alliance for something or other. But the point is that in CLGB, Stuart, with Hymas and Dr. Cohen, had initiated the geriatric oncology committee, or we were called subcommittee. And every time I attended that meeting, I came away very impressed. And this is 20 years ago, that, we ought to make much more formal study and not make it keep it a subcommittee that it was. And I'm glad that now it has blossomed into a much more recognized SIOG, Society International of Geriatric Oncology, and Dr. Balducci and Dr. Exterman and Dr. Littman truly deserve our great thanks for educating us. An important fraction, large fraction of oncology is now being properly addressed. And this program, you forced me to think about geriatric oncology from the program today, and I was very impressed that the diseases that were chosen to cover were all those which are prominently geriatric oncology, although the ones such as colon and breast and that have not been included, they have an age distribution of 2 or 3 peaks in ages, whereas lung, prostate, myeloma, CLL, and what else is here, and melanoma are dominantly, if not predominantly, geriatric diseases, and we mix them up with the general age range of oncology, and thereby these important principles of these age group diseases get by default neglected. I'm not criticizing anybody, because we all meant well when we all 30, 40, 50 years ago, when we started a formalized field of oncology, the drug companies, the FDA, the NIH, NCI, they all required that you are testing any drug, be sure that you do not do any harm by testing liver function tests. that not be worse than 2 times the upper limits of your respective lab or renal functions, etc., etc. By doing that, we were really eliminating older people. We did not recognize. We thought that metabolically it makes sense. But inadvertently, we have been neglecting the geriatric population with the common acceptance that we are doing the right things because ultimately physicians do no harm. Tables have turned. And now this organization is forcing us to look at those people whom we were rejecting. Now, I'm not saying just LFTs and BUN creatinine, but where this leads us to is what Stuart's first introductory lecture educated us, that there are people who have all those things and yet demand attention, treatment, and some appropriate address. So I will go over the same example as I just defined of neglect in the field of CLL or chronic lymphocytic leukemia. I want to pay special tribute to Dr. Balducci because he, along with Dr. Exterman, have in published literature been the pioneers in starting the formal field of geriatric oncology, and we should remember that. Now, oh yes, thank you. Thank you for. He was. I mentioned him in CLGB long before you were there. Now he is a very, very modest person. We'll have to pay him some money. Thank you. CLL is a classic example of elderly cancer. But because the numbers are relatively fewer than the numbers of lung cancer and prostate cancer, etc., therefore, CLL has not been included in the mainstream geriatric oncology where appropriately it belongs. Because as one of the questions that we were asked to answer, and that those questions will come back at the end of the day, is to the median age at diagnosis of CLL is. I don't know what the correct answer will be in the final slide. But when you look at all the SEER data, American Cancer Society data of incidence and epidemiology, it fluctuates anywhere between mid-60s to now lately it has been 72 years of age is the median age at diagnosis. Granted that more with the availability of blood counts for a drop of a hat these days, we are seeing younger and younger people with the diagnosis of CLL. But still, the patients in the age group of 40 to 50 form approximately 5% of all CLL people, whereas people older than 70 and 70 to 80 and 80 to 90, etc., form 65% of the entire CLL population. So CLL essentially is a geriatric disease. And as has been shown by all the previous speakers, that with aging, we come with the compromised function. And therefore, the reason for neglect, that is, you don't want to throw heavy-duty chemotherapy at a person who is uncontrolled diabetic, 85 years of age, and has prostate cancer. So, and those are the real life patients. And we criticize that we have neglect. Now we are going to address those people more directly, but with what is something which we have to talk about. Elderly CLL patients are underrepresented. We were talking during the coffee break about the fludarabine and fludarabine containing combination chemoimmunotherapies, which have become today's standard of care, practically gold standard, brought to us by Dr. Michael Keating at the MD Anderson Cancer Center almost 20 years ago. And what we found 15 years later, 3 or 4 years later, was that in order to not to hurt people who are vulnerable, only fit patients were being treated with FCR. And therefore, in subsequent other trials as well, elderly patients with any compromised function were eliminated, were excluded. And therefore, when the drug or the combination treatment becomes FDA approved, then we as treating what we call ourselves healthcare providers are faced to handle is what to do with the classic representative of that disease, that is the elderly compromised person, once the FDA has approved a treatment. And that is where I hope that SIOG will try to get us out of this confusion. A short description about, look at the bottom line. Age 75 or older represent 40% of all CLL patients, and mean comorbidities of all other cancers is 4.2. That's a high. These are arteriosclerotic heart disease, diabetes, hip problems, or whatever. Whereas when you look at the less than 54 or 54 years of age, they form 10% of all CLL patients, and by this standard, there were really no additional morbidities. In between, you see increasingly the decade 55 to 64, 20% of all CLL patients, and practically 3 comorbidities. And as we get older, 3.6 comorbidities. And therefore, these comorbidities force us to address the issue that you have a diagnosed CLL patient. He is elderly, has comorbidities. What is the right thing to do to tell the patient, to recommend for treatment, to discuss with the family, etc. We have talked about CGA at length today, and I think CGA as a starter, because all the formulas that we come up with, and I was mentioning earlier that in this week's or last week's Blood, there is Colombo's multiple myeloma paper, which talks about a formula which will have classifying elderly myeloma patients into fit, mildly frail, and frail. And they show that there is a clear relationship to survivorship by that criterion. What we have to do, and Dr. Lichtman talked about this, that whatever proposal we come up with ought to be something which is clinically doable without resorting to a mnemonic or having a cheat sheet in our pocket so that we know exactly how to classify that. And that is not easy. But now I'm told Karnofsky performance status or ECOG status is no longer as good as any of these other things. But if they are as good as Karnofsky, then it ought to be simple and applicable. As I mentioned earlier, in FCR, everybody demonstrated that there's the best results, but because of myelotoxicity and immunosuppression, the use of FCR among medically less fit patients was more toxic, and therefore we had to come up with some alternative solutions. I will spend my discussion this afternoon or this morning on these three bullet points. Monoclonal antibodies, more importantly, the newest entrant among rituximab and ofatumumab, the two anti-CD20 monoclonals which have been in use, rituximab, for more than 20 years now, and we have a lot of experience with that, singly as well as in combination. OFA was only about 7 years or 6 years ago that it was introduced. And this new drug, GA101 or Obinu, was only 2.5 years ago, 2 years ago was introduced. And then the two very much exciting but more somewhat exaggerated magic bullets. They are indeed extraordinary as far as CLL treatment is concerned, and they are also especially noteworthy because they can be useful for the elderly and people with the comorbidities, which all other things that we had previous to that were not appropriate. But right now, these ibrutinib and idelalisib, the B-cell receptor signaling inhibitors, are approved for relapsed and refractory disease and now slowly inching into frontline. But that is one of the things that has to be worked out. And then finally, combination of B-cell receptor inhibitors or TKI inhibitors with monoclonal antibody, the ultimate potential non-chemotherapy drug that we had been talking about in the prostate cancer discussion. So in today's times, in frontline, as we know that symptomatic CLL patients who are over 70 years of age, the US FDA approved frontline treatment is obinutuzumab plus chlorambucil. Chlorambucil, as many of us had been thinking that it has been so old and so ineffective that it is virtually a how the FDA also has used chlorambucil, because when pharmaceutical companies went to FDA with the newer drugs, one is bendamustine, they said test it against chlorambucil, the standard approved CLL drug. Naturally, anything against chlorambucil will come out a winner. When they went with the Campath, FDA allowed Campath to be tested against Leukeran, chlorambucil, and Campath came out a winner. Both of those, bendamustine got approved because it beat the hell out of chlorambucil. Similarly, Campath did too. But here the Germans very wisely combined the new anti-CD20, which was eventually called Obinu, it used to be called GA101, with Leukeran, with good reason, because they wanted to use it in people who were not, the Germans call classification in geriatric and non-geriatric patients who are called go, slow go, and no go. No go are the frail, slow go are some in between that we are talking about, and go are fit. So the Germans did a randomized trial with obinutuzumab and Leukeran, which combination I'll go into further details in the subsequent slides. Second is bendamustine rituximab or FCR, but with reduced doses to take care of the potential significant myelotoxicity with these standard doses of FCR or BR. And then finally, clinical trials with the ibrutinib or idelalisib with or without Rituxan. A few points about obinutuzumab, that the mechanism of this anti-CD20 is essentially similar to those of Rituxan and OFA, but it has more apoptotic activity and it has more phagocytosis. Combination with chlorambucil was the one which a large randomized study that showed that three-way randomization. Chlorambucil alone, obinutuzumab plus chlorambucil, and rituximab plus chlorambucil. In the monoclonal combination, there were more than 200 patients in each arm and 118 in chlorambucil alone. overall remissions were, as we knew about chlorambucil before, 30%, whereas it was slightly but statistically non-significant increase with Obinu plus chlorambucil versus rituximab plus chlorambucil. But the complete remissions in Obinu were significantly higher than complete remissions in rituximab plus chlorambucil. And complete remission, as we all know, are generally not seen with single-agent chlorambucil in frontline treatment of CLL. And the cytopenias, toxicities are as expected, but D-level, nothing extraordinary. The overall survival, the dark blue top curve is Obinu plus chlorambucil against chlorambucil. Now here comes the sleight of hand with the FDA, because they do not show Rituxan plus chlorambucil, because that curve comes very close to Obinu, but this was an FDA-approved trial testing against chlorambucil alone. Clearly comes out winner. So we are now left with frontline use in elderly people who are not completely fit in many respects, with one single FDA-approved treatment, and that is Obinu plus chlorambucil. And people are concerned because in contrast to our experience, or even with ofatumumab, where we have a lot of oncology nurses are very familiar with these two monoclonals. They know how to handle. There are shaking chills and shake and bake and whatnot, but they can be dealt with. Whereas the reactions, the first infusion reactions with this new monoclonal can be horrendous, frightening. But we are new in terms of time period in our experience with Obinu, and I am not a partisan pushing Obinu, but I have seen from our experience in the last year and a half that this combination is powerful and yields excellent and longer lasting remissions. So now we move on to the B-cell receptor on the lymphocyte membrane surface turn out to be of critical importance, because the downstream, what the signals that go into the function of the lymphocyte are very important. They control the trafficking, how the lymphocyte will be asked to sit and stay in the solid organs such as lymph node or spleen or bone marrow. What makes it move out of there into the peripheral blood circulation? What level does it proliferate, multiply, and divide, or not? So everything that happens to the cell is governed by the messages that B-cell receptor sends it. Whether the cell will sit without doing anything and therefore have a very long lifetime. And those signals are controlled by critically important few enzymes. So the pharmaceutical industry deserves credit for coming up with inhibitors of those several key enzymes which make B-cell receptor do what it does. One of those enzymes is Bruton tyrosine kinase, BTK. The other one is PI, one of these places. And the two enzymes could come up with the inhibitor chemicals which did the trick of stopping B cell from sending its messages. Therefore, the cell could be killed, chemotherapy vulnerable, and all that. So there are two drugs in BTK inhibition. The CC292 is still in phase 1 clinical trial. So we will talk about ibrutinib, which has been FDA approved, and PI3 kinase delta isoform inhibitor is idelalisib, and then there is a second drug in advanced stages of current clinical trials, IPI 145. So we'll start with ibrutinib. Ibrutinib for elderly patients in frontline, small trials, because ibrutinib was, until a year and a half ago, was concentrating on relapsed and refractory CLLs. And now it shows in frontline significant activity in elderly people with comorbidities whose LFTs or creatinine, etc., might not be up to snuff. So 13% CR, overall remission 70%, and tolerable toxicity profile, most of them grade 1 and 2. Combining with rituximab, particularly in the high-risk patients, there was an astounding 90% overall remission and 8% complete remission, which is very encouraging. At 18 months, overall survival was 80%, and those who had deletion 17p, which in people with active CLL bodes practically death sentence, that these people were alive at 18 months, which is quite a promising start. All of us who have used ibrutinib as single agent treatment know that as soon as you start, this is by oral usage, immediately the big bulky lymph nodes melt away, start to melt away, and dramatically those cells pour out into peripheral circulation, causing further increase from the baseline lymphocytosis to hyperlymphocytosis in the circulating blood. But when you combine with with the rituximab, that hyperlymphocytosis is avoided because those cells are killed, and the dramatic shrinkage of lymph nodes, as you see in the two CT scans before and after, marked degree of shrinkage, so that there is a an objective evidence of combining rituximab with ibrutinib and having therapeutic activity. I mentioned about 17p deletion. Ibrutinib was approved about 4-5 months ago in frontline, backline for 17p. This is the first drug that the FDA has approved for CLL with 17p deletion. Until then, the only effective and curative and predictable therapy was an allogenic transplant with stem cells, related or unrelated, but in reduced dose conditioning. But now we have for 17p deleted CLL patients an effective therapy, not a cure. So that is where I was critical of, that we all become so enthusiastic that we think that this is a cure. Well, we know from CML experience that imatinib was a dramatic quantum leap in therapy of cancer, but it is not a cure. Similarly, these two drugs are a quantum leap over FCR or BR, but it is not a cure. Nonetheless, it is an important step forward for 17p people who had nothing else, because what percentage of actual patients are candidates for allo transplant? Very small. They're here, every 17p deleted patient is a candidate for ibrutinib. And look at this. This is a single curve. There is nothing to compare because this was not, they were not asked to compare it with Leukeran. But it is amazing. It goes on to 12 months and the survival is still at approximately 80%. 17p with active disease have approximately 6 to 8 months of median life expectancy, and 50% is far at the 12-month mark. So most frequent grade 3 or 4 AEs are neutropenia, anemia, pneumonia, hypertension, hemorrhage. But less than grade 3 and 4 are numerous but dealable. So, in summary, ibrutinib given orally has low level of myelosuppression and is a useful agent, probably in combination with other non-cytotoxic therapies. Going into idelalisib. Also similar enzyme PI3 kinase in BCR signaling inhibition, and has been used both single agent, but most of the phase 2, phase 3 trials were in combination with rituximab. Overall response rate 70% against rituximab alone, and at 12 months progression-free survival rate was very high in Idela plus Ritux versus placebo plus Ritux. It was a statistically significant improvement with an acceptable safety profile. And these patients had 65% in the elderly age group. So the clinical trials with the novel tyrosine kinase inhibitors, big hope for elderly, physically unfit CLL patients. Now, some newer drugs. The other PI3 kinase inhibitor is IPI, but more importantly, I would like to talk about ABT-199, a BCL2 inhibitor. BCL2, as you all know, is inhibitor of programmed cell death. And by having ABT-199, either singly or in combination, you have a handle on CLL. And at the last ASH in San Francisco 4 months ago, a phase 2 dose of ABT-199 plus Rituxan in relapsed refractory CLL. It is a selective orally available BCL2 inhibitor, and a reasonable number of sample size, median age 68, prior therapies 3. Most of them were refractory to other treatments and had bad prognostic markers. Overall response rate was 80%, 88%, and complete remission in 32% of those, which is quite extraordinary. And I think that this drug is likely to come before the FDA in the foreseeable future. It had run into some hard time because of its efficacy. It caused tumor lysis syndrome and 2 deaths in the first 3 months of its initiation in clinical trials. So that was shocking. It was good that it had evidence of such an extraordinary activity against the disease that the patient would have a life-threatening tumor lysis. But nobody likes to have that level of activity. So they backed off. It is an oral drug, but right now the drug company which is sponsoring it has required that in all the clinical trials, the patients must be hospitalized for the first 48 hours for safety purposes to make sure that the creatinine does not shoot up, or uric acid, or potassium, LDH, etc. And with the caution and reduced dose, no further deaths in 120 patients treated since, tumor lysis observed by blood chemistry but not clinically, and therefore everybody feels somewhat comfortable that the drug has a future and is likely to be presented. Overall response rate was high and equally high in relapsed refractory patients, complete response rate, and the dose, optimal effective dose, 400 milligram PO. And right now, a large study is currently ongoing. I'm not sure whether there will be an ASCO abstract, but comparison of ABT-199 plus Rituxan versus bendamustine plus Rituxan. Now, after my longish introduction, it is appropriate for us to, at the end, discuss what have we achieved. And in my opinion, what SIOG has achieved and what simultaneously CLL treaters have achieved is to give elderly CLL patients some attention, which they had not been given before. And when I say that, it was not a malignant neglect. It was a benign neglect because we did not know then, 10 years, 15 years ago, how to protect these patients. Therefore, we avoided giving myelotoxic, dangerous drug combinations. That the new enzyme inhibitors are definitely a boon, and we will see more of it as we gain more experience. Are they superior? We've got to find out. Are they superior particularly in the elderly people? We've got to find out. And that is where your interest is very important. And I do want again to end with my appreciation and thanks for making this international organization a reality in United States. Thank you very much. Now there is a case.
Questions? Oh,
Yes, questions, yes.
did you have a question, Dr. Balducci? You can. No, you can.
Yeah, let's do
In
that.
fact, two questions. The first one, how concerned you are about the Richter transformation with ibrutinib? This is coming on over and over again, and I'm wondering if that is... and the second question is, why in the study comparing venetoclax and rituximab, they use bendamustine instead of fludarabine as a control? Thanks.
Yeah. The second question, it was easy because there were elderly people and nobody wanted to use FCR. And whereas with bendamustine, we have much more leeway of giving reduced dose. And the package insert for benda is 90 or 100 milligram per meter square on day 1 and again on day 2. But in these trials, we could reduce it to 65 milligram per meter square, thereby not making unnecessary myelotoxicity. And efficacy-wise, in those patients, it is equally effective. Now, what was your first?
The concern about...
Richter. Richter is a equal bad disease as 17p. And so far, there is nothing that anyone can offer. Although everybody that I talk to has had 2 cases with EPOC or 2 cases with R-CHOP or whatever. But when we put all those data together in significant numbers of people tried, we have 0 to offer. It's a bad prognosis. The life expectancy after a CLL transforms into a diffuse large B-cell lymphoma is in the order of 6 months. And these drugs are now being tried, both of these drugs, in investigator-sponsored trial. Interesting that the drug industries, pharmacyclics for ibrutinib and Gilead, pharmacyclics is now Janssen for ibrutinib and Gilead for idelalisib, did not themselves sponsor any Richter trial. But investigator-sponsored trials are currently underway, and 3 people I talked to at Dana-Farber, at Memorial, and at my own institution, and CRC, the CLL Research Consortium, headed at UCSD by Tom Kipps. They all are having difficulty in getting accrual. Accrual because the protocol would naturally require a repeat lymph node biopsy on a CLL person who is now, most of those biopsies have already been done and are being in formalin. So a repeat before we can put the patient on study, and there is a question about that. If you think about it and suspect it, then you do a biopsy, but before doing the biopsy, enter the patient. It's systems-wise, logistically, a little hard to get collaboration among participating institutions. But
do you think that ibrutinib is associated with an increased risk of richter?
there has been some anecdote, but curiously, ibrutinib is a key part of the planned treatment because the Dr. Balducci's question was that there have been talks that people getting ibrutinib have a higher percentage of Richter transformation. It is possible, but then these advanced CLL patients who have had multiple treatments in this relapse refractory setting, they are prime subjects for developing Richter. And when they develop Richter and they have been on ibrutinib, do we automatically accuse the most current treatment for this development, or it is the progression of the disease itself? You see, Richter's it's a curious thing. That is it always a clonal evolution of the same clone into this malignancy, or is it because of the prior DNA poisons that we have given to the patient which has caused? I think to some extent some patients are from the first reason and some from the second reason, but not exclusively from one or the other. Therefore, yes, ibrutinib has been talked about as a possible increaser of Richter, but it is not clear. Okay. So we are, how are we doing with the time?
We're doing good with time.
We are doing
Yeah,
all right.
fine. You can go to the case.
Okay. So the case. An 80-year-old presents with bulky nodes and white count or lymphocyte numbers of 150,000, anemia, thrombocytopenia, and dependent in IADL. Essentially the kind of case that I talked about in my question after the prostate talk. Lived in assisted living center, no real B symptoms, diabetic, hypertensive, creatinine of 1.8. A classic example for geriatric oncology group to consider, because absent all these complications, because the new drugs, ibrutinib, idelalisib, have only been approved for relapsed refractory patients. Therefore, they are unfortunately not usable here, excepting if we had found that this patient had 17p deletion, which we don't. Therefore, we were to revert to the gold standard, FCR or BR. And as I said earlier, in this 80-year-old with this kind of creatinine, I might not go for FCR and might go for BR. But this is open to our joint discussion. Any suggestion that comes to your mind as a possible treatment. If not, I have a slide. Consideration for initial therapy, BR, chlorambucil prednisone, fludarabine rituximab, observation. Is the only thing that is FDA approved is obinutuzumab plus chlorambucil. So, as I said, ibrutinib is unfortunately out, because otherwise with the big bulky adenopathy and all that, I would have said that ibrutinib is a good choice. BR with reduced dose B, chlorambucil prednisone is the old standard, which we all feel comfortable knowing that it doesn't do much, and FR, observation. And I would say that observation alone should not be discarded, because in some frail elderly, if we are not willing to give leukeran and prednisone, observation is an appropriate thing, particularly if the patient offers no B symptoms. The B symptoms are profound weight loss without trying, drenching night sweats, frequency of infections, major league fatigue. This patient does not have any of those. He is apparently, hopefully, happily living in his assisted living situation. But right now, the correct answer is obinutuzumab plus chlorambucil, but the package insert does not talk us into assisted living and transportation part, which probably are not available. In that case, I would say chlorambucil plus prednisone or observation. Any challenges, attacks on those, Dr. Littman?
Not a challenge, but would you, because you think ibrutinib ideally would be the best therapy? Because the other drug you had mentioned, which I have never given a patient, the one that is FDA approved, you mentioned causes infusion reactions and tumor lysis syndrome, which in this patient would not be a good thing. You put someone on chlorambucil prednisone for a week, a month, say they're not benefiting, and then switch them to ibrutinib.
Yeah, I agree. You see, ibrutinib and idelalisib, we have to remember that the baseline absolute lymphocyte count is 150,000. So we have to be prepared that this 150,000 as a single agent with this drug, any of these two drugs, can go up to 300,000. But fortunately, that does not lead into hyperviscosity syndrome requiring leukapheresis or tumor lysis, etc. But I would say that in this particular case, either observation or the most practical chlorambucil plus prednisone, watching diabetes carefully in the assisted living. Okay, you have been good audience and you are ready for lunch.
Thank you, Dr. Wright.